Hello everybody and welcome to our module on fungal skin infections. So by way of review, there are three general categories of fungal infections. The first are the pneumonias, which I talk about in a separate module. We will talk about the skin fungal infections in this module. And then finally, there are opportunistic fungal infections that occur in people who are immunocompromised or otherwise vulnerable to one of these fungi. So some of the most common fungi that cause skin and nail infections are the dermatophytes. The dermatophyte is a group of fungi that all subsist on keratin, and they cause many types of fungal infections, including tinea pedis, which you may know as athlete's foot, tinea cruris, which you may know as jock itch, tinea corporis, which you may know as ringworm, tinea capitis is a scalp infection, and tinea unguium is a nail infection. When you see the word tinea, it generally means a fungal infection of the skin or nails. Most of them are caused by dermatophytes, but not all. We'll talk about tinea versicolor in this module, which is not caused by a dermatophyte. And then finally in this module, we'll talk about sporothrix, which is a unique sort of fungal skin infection. So let me just review a little terminology before we go on. So as I mentioned before, tinea means a fungal skin or nail infection. And dermatophytes are a group of fungi that require keratin for growth. And most tinea infections are caused by dermatophytes, but not all. And some people mix these two up and think that a tinea infection means a dermatophyte infection. That is not necessarily true. We'll talk about tinea versicolor in this module, which causes a skin infection. It is a fungus, it's a tinea infection, but it is not caused by a dermatophyte. So the dermatophytes are a collection of fungi, and the majority of infections come from three dermatophytes. The first one is called epidermophyton, and it's got the word epidermis in it to remind you it causes skin problems. The second one is trichophyton, and the third one is microsporum. All of them consume keratin, as I said before. That's what makes them dermatophytes. A very important thing to remember, this can be helpful on board exams, is that these exist only as molds with hyphae. So you're never going to see budding yeast or anything like that on a biopsy or a specimen of these. You're always going to see hyphae. Most of them are treated with topical antifungals like cotrimazole and miconazole. These are members of the azole family of drugs. Some of them are treated with another drug called terbinafine. And one thing to note here, just so you don't get confused, is that nystatin is not effective against the dermatophytes. Nystatin is used for cutaneous candida, which is a diaper rash that occurs in babies, and I talk about this in the module on opportunistic fungi, but just remember that you would never use nystatin for one of these dermatophyte skin or nail infections. So many times these infections are diagnosed clinically. You just identify it on site, but if you want to do a test to confirm that a fungus is the cause of the infection, the test of choice is usually the KOH prep. So to do this, you take a scraping of one of the fungal infections, either the skin or the nail, and you add potassium hydroxide. The potassium hydroxide dissolves the epidermal keratinocytes, and then you can see the fungi under the microscope. What you will see is the hyphae. And this is used to diagnose not just the dermatophyte infections. You can also use it for tinea versicolor and candida. We'll talk about the findings of tinea versicolor in a little bit, but for all of these fungi infections, the KOH prep is a useful test. So let's go through the dermatophyte infections one at a time. The first one is tinea unguium, which is also called onychomycosis. It's a fungal infection of the nails. Usually it's the toenails. This is a picture of it down here. It's mostly a cosmetic problem for obvious reasons. People don't like their toenails looking like this. And it's very difficult to treat topically, so usually oral treatment is used either with terbinafine or itraconazole. You have to take the medication for several months to clear the infection. Tinea pedis you may know by its other name, which is athlete's foot. This is a fungal foot infection, and it likes to infect feet in a warm, moist environment. So that includes sweaty feet and feet in locker rooms, especially if they have little abrasions on them. The result of the infection is itchy red erosions, classically between the toes and on the soles. And if you don't treat it, you can get scaling on your feet. You can Google this online and see some pictures of nasty feet with scaling from tinea pedis infections. And this is usually treated topically, so topical antifungals like clotrimazole and miconazole. You can also use terbinafine. Next dermatophyte infection is tinea corporis, which is also called ringworm because it classically forms a ring on the skin, just like this picture down here. It's a skin fungal infection. It's itchy. It's usually circular or oval. It's got red, especially at the edges, and it's usually described as a scaling patch or a plaque. It spreads centrifugally, so it starts in the middle here and moves out like in this picture. The border is usually red, but there's clearing in the center, and that's what makes it look like a ring, so that's why it's called ringworm. And this can be treated topically with antifungals like clotrimazole and miconazole and also terbinafine. Tinea capitis is a dermatophyte infection of the scalp. It usually occurs in children, and it presents as a red scaling patch on the scalp, often with hair missing.
and then it can spread centrifugally just like all the dermatophyte infections. Shown on this slide is a picture of a person with tinea capitis. You can see this circular plaque here where the hair is missing. That's what tinea capitis can look like. It can also be red, and the patch can be described as scaling. And much like the nail infections, oral treatment is often used for tinea capitis. So drugs like griseofulvin, terbinafine, or itraconazole are often used to treat this infection.
Tinea cruris is also called jock itch. This is a fungal infection of the groin. It's more common in men. It's common after physical activity. When you sweat, that creates a favorable environment for the fungus, especially if you don't shower well. This is a picture of it down here, and you can see that this man has this red, well-demarcated plaque in the groin, and that's pretty classic for jock itch. Obesity increases the risk because when you're obese, you have deep skin folds here in the groin where the fungus can hide and thrive. It presents as a red patch on the inner thigh and spreads centrifugally, and the key is a red, sharply demarcated border, just like you can see in this picture over here. This can be treated topically with clotrimazole and miconazole and also terbinafine. The next fungal infection is called tinea versicolor, and all the infections named tinea we've discussed up till now have been dermatophyte infections. Tinea versicolor is the one exception. It is called tinea, but it's not caused by a dermatophyte. It also goes by the name pityriasis versicolor, and it's caused by species of fungi called Malassezia. These are dimorphic fungi. This is very different from the dermatophytes. Remember, the dermatophytes exist only as a form with hyphae present. These fungi can exist as yeast or a mycelial form. They're part of the normal skin flora, but sometimes the yeast on the skin can transform into the hyphae mycelial form, and this is what causes disease. And triggers for transformation include hot, humid weather, sweating, or topical skin oils. So as you can imagine, people that come back from a tropical vacation to the beach are at risk to develop tinea versicolor. What this fungi does is it degrades lipids, and they turn into acids, and these acids can damage melanocytes, and the result is hypopigmented skin. This is a picture of tinea versicolor down here. And remember what I said before, it's not a dermatophyte because it does not consume keratin. Now, one thing to keep in mind, this is often someone who's just come back from a beach vacation. Remember that the warm, hot, humid sun is a trigger for this infection, so they will come back and be very suntanned, but they will complain that there is a spot in their skin that is not suntanned, and it will look something like this. And the reason it looks like this, the reason it's hypopigmented and not suntanned, is because they have a fungal infection of their skin. A high-yield thing to know about this fungi for your boards, especially step 1, is that the KOH prep will show hyphae and yeast cells. Remember that for the dermatophytes, you're never going to see yeast cells because they don't exist as yeast. And the presence of both hyphae and yeast is often described as spaghetti and meatballs. This is a picture down here, and this is another picture here. There are even better examples you can find in textbooks and online. But what you see are hyphae like this right here, and then you also see the little yeast forms, which are circles, and so that's described as spaghetti and meatballs. You treat it topically with azoles. There is also a topical medication called selenium sulfide. This promotes shedding of the stratum corneum, which you may recall is the uppermost layer of the epidermis, and when that sheds off, it will often rid the body of the fungus. The final fungal skin infection we'll discuss is that caused by Sporothrix schenki or schenka, and this is the causative agent of sporotrichosis. So Sporothrix is a dimorphic yeast that lives on plants, and what happens is you get spores introduced into your skins with little trauma. That's why it's called rose gardener's disease, because rose gardeners will get irritated hands from working in the garden, and then the spores will get into their skin. What happens is a few days or even weeks later, they'll get a papule at the site of trauma, and then the fungi travels up the arms via the lymphatic channels. This is a process called ascending lymphangitis. As a result, they will end up with similar lesions all along the lymph channels going up their arm from the hand up to their shoulders. So the classic picture to show you on their boards, and you can find examples of this online, is someone who's got a papule down near their hand, and then they've got little papules going all the way up their arm to the shoulder. This is often diagnosed clinically just by recognition of the classic rash, but you can also diagnose it with a fungal culture. And there are two possible treatments. The first is to use oral itraconazole, and the second is to use a very unusual treatment called saturated solution of potassium iodide, or SSKI. This is a very old therapy. It's over 100 years old. And what you do is you take drops of potassium iodide and you put it in juice or milk. And if you drink that for a few weeks, it will clear the infection. The mechanism is not clearly understood. A lot of people can't tolerate it because of nausea and other side effects. So a lot of people use itraconazole to treat this, but SSKI is still an accepted therapy for sporotrichosis. And that concludes our module on fungal skin infections.